All right, welcome everyone to The Explainer. Consider this your essential, totally comprehensive Psychopathology 101 lecture. I am absolutely thrilled to be your guide today as we explore the incredibly fascinating and honestly pretty complex world of mental disorders. Today, we're going to master the clinical realities of the human mind. We'll cover everything from how ancient civilizations viewed brain surgery to the cutting-edge therapies we're using right now in modern clinics. My goal? Well, it's to make sure you're not just familiar with this material, but completely exam-ready and super confident in your understanding of clinical psychology.
Okay, let's dive into this. Here is our syllabus for today. First, we'll define mental health, then look at historical etiology, followed by diagnostic frameworks, then we'll do a deep dive into anxiety pathology, and finally wrap up with therapeutic treatments.
So, starting off with Chapter 1, Defining Mental Health, where we'll establish our clinical terminology.
Now, in medicine, precision is literally everything. Before we even think about diagnosing a patient, we absolutely must get our clinical terminology straight. People tossed around terms like mental health problem, mental illness, and mental disorder all the time in everyday conversation. But in our field, they mean very distinct things. I want you to think of mental health issues like a giant hierarchical pyramid. Down at the broad base, we have mental health problems. These are just your everyday stressors, a temporary bout of anxiety or feeling down for a few days. But as we move up the pyramid, when symptoms get more severe and start checking off specific clinical boxes, we enter the realm of mental illness, something like schizophrenia. And finally, at the very peak, when these conditions become deeply entrenched, incredibly severe, and absolutely demand clinical diagnosis and targeted treatment, we classify them as mental disorders, like intellectual disability or ADHD. We rely on this hierarchy to figure out if someone is just hitting a temporary rough patch or if they need serious clinical care.
Okay, please star this next concept in your notes because it is absolutely crucial. The biopsychosocial model. This is the fundamental lens through which all modern psychiatry views mental illness. Basically, it means we no longer think a disorder comes from just one isolated place. It's always a combination. Bio refers to biology, your genetics, your physical brain structure. Psycho is about psychological stressors, things like early childhood trauma or unhelpful thought patterns. And social covers your environment, which could be anything from your financial situation to your relationships with family and friends. To trigger a mental disorder, a patient generally needs the right, or actually scratch that, the wrong combination of these two factors. Moving on to Chapter 2, Historical Etiology. We're going to trace the origins of mental illness.
Real quick, etiology is just the fancy medical word for the cause of a disease. And to truly grasp how we treat patients today, we have to look backward at how our ancestors tried to cure the mind. And trust me, it has been a wild ride. We're talking 8,000 years ago, people believed in supernatural theories, literally thinking you were possessed by evil spirits. Fast forward a bit to 400 BC, and the Greeks shifted to somatogenic theories, meaning they realized the physical body was the source of the illness. Skip ahead to the 16th century, and society's big medical breakthrough was, well, just locking people away in asylums. It wasn't until the mid-20th century that we finally saw the rise of psychopharmacology, which is just medications designed for the brain, and the widespread acceptance of that biopsychosocial model we just talked about.
Let's look a little closer at one of those earliest treatments, because honestly, I find this mind-blowing. Trephination. This was an ancient surgical procedure where a doctor would literally scrape or drill a hole right into a living patient's skull. Originally, the idea was to release trapped evil spirits that were supposedly causing erratic behavior or seizures. But here's the crazy part, the survival rate. Archaeologists have dug up thousands of trypan skulls, especially in places like Peru, showing smooth, completely healed bone. That means the patients actually survived. Think about that. These ancient practitioners, working outside with literal stone tools, were achieving survival rates that vastly outperformed leading 19th century European hospitals where patients were constantly dying of infection. It really makes trephination an incredible, albeit gruesome, early ancestor of modern neuropsychology.
So, fast forward again to ancient Greece. Hippocrates comes along and completely rejects all that supernatural stuff. He introduces humorism. This was a somatogenic theory stating that the human body contained 4 vital fluids, or humors: blood, yellow bile, black bile, and phlegm. Each fluid was tied to a specific organ and even a specific season. Hippocrates argued that if these fluids got out of balance, you became mentally ill. So, for example, if you were acting overly temperamental or manic, a physician would say, you have an excess of blood. And the treatment? Bloodletting. They would literally drain blood out of your body to restore the balance. Which brings us to Chapter 3, Diagnostic Frameworks.
let's look at how we identify and classify disorders today.
Thankfully, we no longer balance humors or drill holes in skulls to let demons out. Today, we need scientific precision. But diagnosing a mental disorder is uniquely tricky. It's not like a broken arm where you can just take an x-ray. The absolutely vital concept here is understanding the boundary between normal behavior and disordered functioning. Let's use anxiety as an example. Look, everyone feels anxious. Being nervous before a first date, completely normal. It pumps you up, motivates you to look your best, right? But disordered functioning happens when that anxiety becomes so intensely overwhelming that it causes significant impairment. If your anxiety physically stops you from making eye contact or triggers a panic attack so bad you have to cancel the date entirely, it's crossed a line. To be a disorder, it must significantly interfere with your daily life, your work, or your relationships.
And because we don't have a simple blood test for mental illnesses, the global psychiatric community relies on the DSM-5. You can think of this as the psychiatric Bible. It's a massive, highly standardized manual that gives us very specific checklists of symptoms for every recognized disorder. For a doctor to make an official diagnosis, a patient's behaviors and complaints have to strictly match up with the specific symptom clusters laid out in this exact manual.
Now for Chapter 4, Anxiety Pathology. We're going to do a deep dive into anxiety and related disorders.
Let's take that diagnostic framework and apply it directly to anxiety. Anxiety disorders are super common, but the gears turning behind the scenes are quite complex. Remember the biopsychosocial model from earlier? Well, when we talk about anxiety, we call this the triple vulnerabilities theory. Basically, for an anxiety disorder to fully develop, a patient usually has all three of these vulnerabilities. First, a biological vulnerability. Maybe you just have genetics that make your brain a bit more reactive to stress. Second, a psychological vulnerability, like experiencing unpredictable trauma as a kid, which teaches you early on that the world is a dangerous place. And third, a specific vulnerability. This is a learned focus. For instance, if you grew up in a house where every single sniffle or minor cold was treated like a massive life or death emergency, you learn to hyperfocus your anxiety specifically on physical illness. So when life throws a major curveball at someone with all three of these vulnerabilities, an anxiety disorder erupts.
Okay, students, time for clinical rounds. You are for sure going to need to know these differential diagnoses for your exam, so pay close attention. If a patient comes in with constant, uncontrollable worries about just everyday things, that's generalized anxiety disorder. If they're struggling with unwanted, persistent thoughts that practically force them to perform repetitive behaviors, that's OCD. What about a debilitating, paralyzing fear of public humiliation? That's social phobia. An intense, completely irrational fear of one specific thing, like spiders or maybe heights, specific phobia. And finally, if severe anxiety kicks in after a life-threatening trauma, usually along with flashbacks, we're looking at post-traumatic stress disorder.
Let's drill down a bit deeper into generalized anxiety disorder, or GAD, just to see how those strict DSM-5 criteria work in the real world. The manual explicitly states that the excessive worry has to last for at least 6 months. Here's a great little mnemonic to help you remember the difference. Normal test anxiety is being nervous the night before your big exam. GAD is worrying so aggressively about a test that is literally 6 months away that your muscles are constantly tense, you're irritable all the time, and you physically cannot sleep. It's like your brain's alarm system gets jammed in the on position.
All right, final section. Chapter 5, Therapeutic Treatments. Let's explore modern approaches to healing the mind. So once a clinician has successfully used the DSM-5 to nail down a diagnosis, the next big step is choosing the right evidence-based treatment path to actually help the patient heal. Now, the very first formalized talk therapy was psychoanalysis, famously developed by Sigmund Freud. Freud's big idea was that mental illness came from unconscious conflicts between different parts of the mind, the primal id, the hypermoral superego, and the ego stuck in the middle trying to mediate. To dig up these hidden conflicts, analysts use techniques like dream analysis and something called free association, which is where a patient just talks continuously without filtering or censoring their thoughts. While psychoanalysis is historically a massive deal, the reality is it's an intensive, multi-year process that frankly just lacks the strong modern empirical support we see with newer methods. Next up, in the mid-20th century, a guy named Carl Rogers developed person-centered therapy. This is what we call a humanistic approach. Unlike the Freudian psychoanalyst who sits there interpreting your dreams, the PCT therapist takes a very passive, highly empathetic role. They provide what Rogers called unconditional positive regard. That simply means they never, ever judge or criticize the patient. The whole theory is that if you create a perfectly safe, warm environment, the patient will naturally discover their own self-worth and heal themselves. It's incredibly comforting for sure, but because it relies on this sort of one-size-fits-all blanket of empathy rather than targeted, specific interventions, clinical studies show its actual effectiveness is pretty mixed.
Which naturally leads us to cognitive behavioral therapy, or CBT, pioneered by Aaron Beck and Albert Ellis. You absolutely must know this for your clinical practice. CBT is currently the gold standard. It is the most empirically supported treatment we have for virtually all psychiatric illnesses. It operates on something called the ABC model. A stands for the antecedent event, the trigger, like walking into a room full of new people. B is the belief, your maladaptive thought in that moment, like, oh no, they're all going to hate me. And C is the consequence, the resulting emotion of intense anxiety and the behavior of turning around and running away. What makes CBT so effective is that it actively targets and rewires that B, the belief. The therapist actually assigns homework to the patient to go out and change their thoughts and behaviors in the real world.
I really want to draw a sharp contrast for you here between these two major camps. Think of it like this. Psychoanalysis is inherently backward-looking. It spends years digging through your childhood and your unconscious past, desperately trying to find the root cause of your pain. CBT, on the flip side, is intensely present-focused. A CBT therapist doesn't really care what your mother said to you 20 years ago. They care about fixing your maladaptive thoughts and behaviors right now, today, so you can actually function and live your life.
Within the CBT umbrella, we frequently use something called exposure therapy, and this is especially huge for treating phobias. Let's say we have a patient who's absolutely terrified of spiders. We don't just lock them in a room and throw a tarantula at them, right? We use gradual exposure. First week, they might just look at a cartoon drawing of a spider. Weeks later, maybe a photograph. Then they hold a little plastic toy spider. Finally, way down the line, a real one. By safely and incrementally exposing them to the trigger, we facilitate what's called extinction learning. This isn't just a metaphor, it is the literal neurobiological process where the brain actively unlearns the irrational fear response. Finally, we've seen an incredible shift recently with mindfulness-based therapies. These are actually rooted in ancient Buddhist practices. Therapies like dialectical behavior therapy, or DBT, take a very different approach than traditional CBT. See, if you have a terrible, anxiety-inducing thought, CBT teaches you to fight it, challenge it, and replace it. Mindfulness, however, teaches you to practice distress tolerance. You simply observe the bad thought without judgment. You accept that it's hanging out in your brain, but you actively choose not to act on it. You learn fundamentally that a thought is just a thought. It's not a mandate you have to follow. And well, that brings us to the end of our masterclass today. Just take a second to think about how incredibly far we've come. We started with ancient practitioners literally scraping holes into human skulls with stone tools to let out demons, right? And today, we are using targeted cognitive exercises to neurobiologically rewire the brain's actual pathways. The field of psychopathology is moving so fast, constantly evolving, and as future medical professionals, you are that next generation. So how will you redefine healing? I really hope this lecture has given you absolute clarity for exam, but even more importantly, I hope it sparked your curiosity to keep exploring the incredible, endlessly fascinating intricacies of the human mind. Good luck with your studying, and I'll see you next time.